All right. Okay. Good morning, everybody. My name is Sarah Myers. So I'm sorry I can't be there to actually meet you all in person, but I'm going to be recording a couple of lectures for you over the next couple of weeks. So I was a paramedic. I trained here at QUT and then worked in Queensland and also New South Wales, and now I am a doctor. So today we're going to be talking about abdominal pain and the acute abdomen. So obviously just some objectives for this lecture. So as you can see below, we're going to talk about the regions and quadrants of the abdomen, identifying the main organs of the abdomen. We'll be talking about how to carry out an examination of the abdomen, including some videos, interpreting the findings, including referred pain, to age or diagnosis and treatment, and management of gastrointestinal emergencies. So first of all, with the abdominal quadrant, so hopefully, I'm not sure what subjects you guys are doing these days. For us, when I was here, it was bioscience, but obviously talking about the different quadrants of the abdomen. So there's two ways of looking at it. There's the 4-quadrant view, which you can see here. So right upper quadrant, right lower quadrant, and left lower quadrant. And then there's the 9-quadrant view. Now, often what I find is a lot of people refer to right upper, right lower, and left lower quadrants as the very extremes of those quadrants. So almost as if you were talking about the hypochondric or the inguinal quadrants on the 9-quadrant view. And then they tend to use things like epigastric, umbilical, and suprapubic a lot. The lumbar areas are generally less talked about, but that's just to give you a bit of an idea of how sort of people talk about things. Now, organs in each quadrant. So obviously there's lots of organs in the abdomen, lots of them overlap, but knowing in general where your organs sit helps you determine the possible causes of pain in that area. So looking at our right upper quadrant first, obviously we've got the liver, and particularly the right lobe of the liver, which is quite extensive, so it does take up a lot of that area. The gallbladder is there, the duodenum, which is retroperitoneal, the head of the pancreas, the right adrenal gland, the right kidney, or at least the upper part of the right kidney, the superior part of the ascending colon, and the right transverse colon. Then over in your left upper quadrant, you've got the left lobe of the liver, which is quite central in that quadrant, or basically epigastric. Then your spleen, most of the stomach, the jejunum and the proximal ileum, the rest of the pancreas, the left adrenal gland and kidney, the superior part of the descending colon, and the left half of the transverse colon. Then down in our right lower quadrant here, we've obviously got our cecum and appendix, which are right down here in the corner. Most of the ileum, which is here in the middle, the inferior part of the right uterine tube. So they're important things to remember. The right ovary, so in women we've got to remember our reproductive organs in here. The ascending colon, the right ureter, and the spermatic cord in a man. And then in our left lower quadrant, we've got our sigmoid colon down here, the inferior part of the descending colon, left ovary and uterine tube, the left ureter, and the left spermatic cord. Oh, that did not work out very well. That's a little bit blurry. Sorry about that, but it just gives you a bit of an idea comparing the 9-quadrant view and the 4-quadrant view. But like I said, I mean, there's lots of sort of Google images and you can have a look yourselves, and depending on how you've learnt your anatomy, it's basically just understanding the general gist of which organs are in the areas that you're going to be finding abdominal pain. Now, so obviously one of the most important things with any presenting complaint is taking a history. So history is really important, and realistically, although obviously it's a lot easier with a patient that comes into hospital to make diagnoses because we've got the assistance of blood tests and imaging and all sorts of other things, there's still so much that can be gathered, particularly from a history. And if you take a really good history and follow that with an examination, even at that point, you should already have your differential diagnosis in mind after taking the history, and your examination findings are just supporting your history taking, and then your lab tests and your imaging supports your examination and diagnosis. So taking good history is really important. So obviously we have our list here of, the usual history. So obviously our presenting symptoms, so we're talking about abdominal pain today. So the history of presenting illness, it's really important to flesh out the important parts of the abdominal pain, and we're going to talk about that a little bit separately. So we'll talk about that soon. Then drug and treatment history. So that's important in those patients that maybe have a sort of more prolonged course of illness. For example, if they've been unwell for a week and they've had some abdominal pain and they've seen their GP and their GP has prescribed X, Y, and Z for, whatever they thought they might have. That's important to know when that treatment started, and if it has helped at all or if it hasn't helped. So those things are important. Obviously, if they've ever had this particular kind of symptom before, can often be quite helpful. Then, of course, we go through our past medical history, and the important things, obviously, we want to know all of their past medical history, but pertinent history is something to, I guess it's a bit of a buzzword, but it's something important to be aware of. So we want to know a few things. We want to know if they've ever had anything like this before, what it was diagnosed as. We want to know if they've had any abdominal pain before that had a diagnosis attached to it. And we really want to know about previous abdominal surgeries. So one of the things that we'll talk about later is, for example, bowel obstructions are often secondary to adhesions. So every time someone has an abdominal surgery, because of the instrumentation and medicalization of the abdomen, after that abdomen is closed, the body in its healing process produces adhesions. And they are the most common cause of bowel obstruction. So they basically are sort of tight band-like structures that can then cause constriction of the bowel, which leads to bowel obstruction. So as I said, finding out if they've had any previous abdominal surgery of any sort is important. And then other history that could relate. So always remembering that abdominal pain could be other things, which again, we'll talk about that later, but just other history things that may present as abdominal pain, and then things that put patients at high risk. Now, social history is a little less important in the pre-hospital environment, and a lot of your social history you guys actually pick up from being in someone's home, which is something that I definitely found the difference when I started working in a hospital. You don't get all of that sensory input that you do when you walk into someone's home. So you guys will walk into a person's house and you can see that they live in squalor or they're quite well off, and you can see the packet of cigarettes on the counter and you can see the bottles of alcohol. There's lots of clues that you can get that help you make these decisions without having to actually ask. Obviously, like I say, in hospital, they are questions that we actually have to ask. So again, like I say, it's less important for you to be asking, but it is part of your history taking. The other thing, just on a side note, that I will say, it's always good to put those things in your notes. I know that there's still lots of doctors and nurses that won't read your notes, but I think it's really valuable, and I think you guys get a lot of information that you don't realize when you walk into a home, and so passing on that information is really helpful. Now, family history, again, when we talk about family history, we will often want to know pertinent family history, so we don't really care that their great-grandmother had hypertension and died at the age of 99. What we care about is major abdominal, in this situation, is major abdominal interventions in family members. Have they had has one of the family members had a ruptured abdominal aortic aneurysm in their 40s, because that is a significant family history, as opposed to, like I said, grandma who had hypertension and died at 99. And then we do a systems review. So systems review is something that I was never really taught in that way, that it's a systems review. So I'm not sure if you guys have been taught that or not. But basically what it is just checking the important symptoms that you may or may not have heard about so far. So obviously, when you're asking about abdominal pain, you've done the history on all their pain and when it started and things like that. And you've asked about other symptoms, but there may be other things you want to know. So you can clarify and you can double check, have they had any, you can do it very systematically, as in go through each system, or you can just have a list of sort of pertinent things that you would want to know about. So we often like to ask about chest pain, shortness of breath, nausea, vomiting, problems with urinal bowels, and if that's your summary, that's definitely adequate. It doesn't need to be a lot, but it's just to sort of sum up and make sure that you haven't missed anything. So in terms of our current symptoms, so obviously, like I said, we are talking about abdominal pain. So we like to use Socrates. Hopefully you've been taught Socrates, or you may have been taught a different mnemonic, but the most common one that people use is Socrates. So you can actually use this for any symptom. It doesn't just have to be pain, but it's obviously most commonly taught with pain. So we're going to go through each one. So in terms of the site, so obviously where is the pain? Something that I like to use with abdominal pain in particular, because people will say, oh, it's just in the middle of my tummy. If you ask them if they can point with one single finger to where the pain is, it's often very helpful. Sometimes abdominal pain is very diffuse, and so you won't necessarily get a pinpoint area that they can point to, but it's good to ask and see if they can definitely localize that pain. Sometimes the description you'll get versus a finger point will be quite different. So again, though, even if it is diffuse, asking them, it may be just central abdomen, it may be diffuse but on one side of their abdomen, it may be just a generalized ache that they can't actually pinpoint, but really trying to tease out where is the pain as best you can. So then we talk about onset. So onset's important. Obviously, there's sort of really rapid onset, which we would describe as over a couple of minutes. Then there's gradual onset, which, maybe it's built up over hours to days, and then instantaneous. So that's your sudden onset. That's when we talk about things like subarachnoid headaches, subarachnoid hemorrhages and their headaches. They're sudden onset thunderclap. So that's important to ask. We like to know whether the pain is continuous or if it's intermittent. Does it come and go? And does it get better or worse? So sometimes, obviously, some things make it better or worse. When did it change? So sometimes the change in the pain, so for example, someone may have had pain for sort of grumbling pain for a couple of days and now it's really severe acute pain. That's important to know because that background couple of days may help change our differential diagnosis. And the next thing is what they were doing when it started. So again, these are things that we often like to ask with, for example, our chest pains, our cardiac chest pain, were you exerting yourself when the pain started? Were you just sitting at rest? Those sorts of things. But it's important with abdominal pain as well. Were they straining on the toilet? Were they running around? Were they lying in bed? All those sorts of things are important to know. Now, character. So what does our pain feel like? Now, one of the things that's really important is trying as best as you can to not put words into their mouth initially. So asking the patient, what does it feel like? Can you describe it for me? Explain the pain for me. And giving them some time to try and explain it to you. People will often come up with things, and obviously these are some of, the common examples: sharp, dull, stabbing, aching, burning, cramp-like pain. The classic, again, with our chest pain, someone sitting on on the chest or something like that. So those are important things, and it is really important to try and get them to tell us what the pain is. If you're really not getting anywhere, you obviously can give them some options, but it's good to give them a number of options and let them think about it, as opposed to, is it sharp? You know, because people will often just sort of probably say yes because they want to, I guess, please people. So as I said, yeah, try not to put words into their mouth, and see how you go with that. Then radiation. So does it radiate and to where? So obviously, I mean, that's quite straightforward, but trying to really clarify if it's central pain that's radiating into the left lower quadrant, or if the pain is from the left lower quadrant and radiating into the center of the abdomen. Does it radiate into their back? Is it a band-like pain all the way around the side? So sometimes those things you will hear, you know, it's an upper quadrant pain and it radiates to the back. There's often, sometimes it will just be straight through to the back, and sometimes it's sort of around the side of the rib cage and into the back. So just clarifying those sorts of things. Now, alleviating factors. So obviously, just with the radiation, I don't think it comes up later, so I'll tell you now. Obviously, migratory pain is really important. So one of our classic examples of migratory pain is a classic presentation of appendicitis. And I say classic because, as I'll sort of explain to you when we talk about appendicitis, not all appendicitises present with central abdominal pain that now has migrated to the right lower quadrant. Most appendixes don't actually present like that, but that's the textbook answer that we are taught. So migratory pain is important. Did the pain start somewhere and has it moved? When did it move? What were you doing when it moved? Again, sort of going through your whole Socrates again on when that pain moved and why and how. So alleviating factors. So position is really important, because some things with abdominal pain, you know, being curled up in a ball will make it a lot better. Sometimes pushing on the area makes patients feel better, and they will actually have their hand pushing on the area. Some patients, for example, renal colic, they often just can't sit still. So they'll be pacing, they'll be moving around, they're not comfortable in any position. And obviously, if they've taken any medication, what have they tried? Has it worked? And then when you're reassessing, if you've given them medication, what was it? Did it work? Now, timing, so when did it first start? So this is obviously, it's, you know, these things all sort of run into each other. So it's a little bit similar to your onset, but as I was saying before, it's really important to ask them, if you get called to someone, say, with really severe acute abdominal pain, did they actually have abdominal pain, low grade, sort of general dull abdominal pain for the last 3 days? So the very first onset of symptoms, because that can, as I said, change some of the differentials that you think of. And then obviously our exacerbating factors. So again, position can be another one, can exacerbate it. Eating, so for some of your upper GI issues, eating can definitely make things worse. And movement. And one of the things with movement, particularly with anything, we talk about it a lot with appendicitis, but it's basically anything that has caused localized peritonism, movement, or particularly in the back of a car. So if when they're in the back of the ambulance, every bump on the road they feel in their abdomen, or if they jump, particularly with kids, you can see if they can jump. If they can't jump, then that is a sign of localized peritonism. Now, severity. So obviously severity is quite subjective. Pain itself is a subjective thing to people. Now, we often normally talk about the 10-point scale. Obviously, everyone's different, and what you need to remember is someone may say the pain is 10 out of 10, and it may be for them the worst pain they have ever felt in their life. So that is okay. It's important to then use it as a scale where you can base, you know, your improvements. And if you feel like you're maybe not getting the best answer out of people, one of the things I say, and particularly for some younger people, is You know, 0's absolutely no pain and 10's that the shark has just ripped your arm off. Things like that. Being a little bit over dramatic to try and get the point across that 10 is the worst pain you can imagine. Now, the FACES scale down here is one of the common ones described for children. So obviously, depending on the age of the child, you can ask them to use 1 to 10. You can write the numbers on a page and get them to point to a number. It obviously depends on their child, probably their education level, and also how much pain they're in. Probably if they're in a lot of pain, they will not want to interact that much. But using the FACES scale is also totally acceptable. So you can use that, and when you then describe, when you hand over the patient, you can just say, as per the FACES scale, they were an 8 when we first picked them up, and they're now a 4, for example. So you can use that. There's lots of different scales, but you know, the most commonly sort of referred to as the Wombaker scale, and they all basically look pretty similar. Some people also have pictures of the faces and ask the child to point it out to them. That's another way of doing it. But if children are, obviously if they're quite distractible and things like that, then they're unlikely to have sort of really severe pain up this end of the scale. Now, associated symptoms is important as well. So anorexia, which is basically the feeling of not wanting to eat. So we often ask, have you eaten? Do you feel hungry? Do you want to eat? Nausea and vomiting is important. If they have been nauseated, have they taken anything for it? Has it helped? If they have been vomiting, what was the vomit? Was it just food? Was it just liquid? Is there bile in it? Is there any blood in it? If there is blood in it, clarifying the blood. Is it specks of blood? So, you know, have they just had so much forceful vomiting that they've now got a Mallory-Weiss tear, so tiny little mucosal tears in the esophagus, which is causing flecks of blood in their vomit? Or is it actual clots of blood? Is it old blood? Is it fresh blood? All those sorts of things. We always like to ask about bowel habits. So diarrhea and constipation are the obvious two. The other thing that is important to ask, which again, like probably less important, but important to ask because people won't necessarily volunteer this information, even though you think it's so important and it may be the main reason they called you, they then don't volunteer. So asking about their stools. Lots of people don't necessarily look at their poo unless they've been going a lot or if they're sick, so then they might look. But obviously the things we want to know, the main thing we want to know is blood, and then if it was at all dark, we want to know what it looked like. So when it comes to PR bleeding, which we will talk about more later, you've obviously got fresh, bright red blood, and then there's all sorts of levels of digestion of blood, all the way up to true melena, which is black and sticky. So that's important to ask. The other thing that I haven't put in there that I should have is urinary symptoms. So burning, stinging, the classic symptoms of a urinary tract infection, but they can indicate some other things. So burning and stinging, frequency, needing to go to the toilet a lot, those sorts of things. And then fevers and rigors. So obviously, you know, if they have a thermometer, have they checked their temperature? Do they just feel hot? Have they felt hot and cold? Rigors are can be quite significant, or at least lets you think of other things. So not everyone will get them, and not everyone who's really sick will get rigors. But if so rigors are not just shaking with a fever, and one of the ways that if someone says, oh, I was shaking a lot when I had the fever, if you ask them if you had a teacup on a saucer, would you have been able to keep the tea in the teacup? If they say no, then that's likely they had rigors. It's obviously hard to determine if they truly had rigors without you seeing it or someone else seeing it or witnessing it, whatever. But that's a good way of judging. Some people just get a bit shaky, but true rigors are essentially uncontrolled shaking and shivering. it can be associated with bacteremia. So the release of bacteria through the bloodstream and the endotoxins that go with those bacteria can cause rigors. So like I say, it's important to know it's not something that will always be there as a severe sign if if someone's really unwell, but it's something that's important to ask about. Okay, now, so we're going to talk about abdominal examination. So what I'm going to do is I'm going to play this YouTube video through once with the sound on, and then I'm going to go back and turn the sound of the person talking off and go through the things that I really want you guys to know and that I really want you to be able to do. All right, here we go.
Hi, my name is Adam. I'm one of the final year medical students. Can I ask your name?
Dan Stage.
Hi Dan. I've come to do an examination of your tummy today. So I'll have a look at your hands, have a look at your face, and then have a press on your tummy as well. Would that be okay?
Yeah, that's fine.
Great. Would you mind taking your t-shirt off to begin with?
Yeah, of course.
Okay Dan, I'm just going to have a look at you from the end of the bed. Could you put your hands down by your sides? Okay, I'm just going to have a look at your hands, Dan. So if you could put your arms out for me like this. And if you put your two index fingernails together like that. That's great. If you turn your hands over. And if you turn your hands over again, extend your wrists all the way back and close your eyes. That's great, thanks Dan. And if you could raise your arms up for me. Okay, you can put your arms back down. Okay Dan, I'm just going to have a look at your face, so if you just look straight ahead for me. And if you could pull your lower eyelid down with your finger. That's great, and if you look up at the same time. Okay, that's brilliant. You can stop doing that. And if you open your mouth and stick your tongue out and point it up in the air. That's fine, you can close your mouth, thanks. I'm just going to have a feel around your neck. I'm just going to have a feel of your tummy if that's alright now, Dan. Have you got any pain anywhere?
No.
No. I'm just going to flatten the bed. Are you okay lying down flat?
Yep.
Okay, I'm just going to have a feel of your tummy now, Dan. Tell me if you're in any pain. And I'm just going to press a little bit deeper this time. Can you take some deep breath in and out for me now, Dan? That's great, keep going. Okay, I'm just going to feel the blood vessel in your tummy. I'm just going to tap on your abdomen. If you roll over towards me. That's fine, you can lie on your back again. I'm going to have a listen to your tummy now, Dan. Okay, Dan, that's the end of the examination. Thank you. You can get dressed again now. Thank you. In summary, I examined Dan, who was a 28-year-old male. He had no peripheral stigmata of GI pathology. His abdomen was soft and non-tender. There was no organomegaly, and bowel sounds were present. This is consistent with a normal GI examination. To complete the examination, I would examine external genitalia, hernial orifices, and do a PR examination.
Alright, so as I said, we've been through the abdominal examination the first time, and now I'm just going to talk about this video. So obviously I really tried to find what we call a focused abdominal examination video to show you guys, because I think that's actually far more important for you, but I was unable to find that. So I had to use this video. Now this is obviously a full abdominal examination looking for the peripheral stigmata of disease and things like that. But a lot of that doesn't need to be done, and to be honest, most of that never gets done even in an emergency department. These are for physician examinations and for people on the ward who are really looking hard for different signs and symptoms. So the main things, first of all, so we'll go through and I'll just talk, pick out the points that I think are important for you to know. So obviously this part, the basic assessment, just looking at the patient, which you guys already do, you will have already picked up. When you walk into a residence or wherever you are, you will look at this patient and you will look for all these things. You know, it's obvious if the patient's really obese, it's obvious if they're thin and cahectic. It's not always obvious if they're jaundiced, but you may notice that they are jaundiced. So looking for those sorts of things is important. And just making a mental note of them and recognizing that they are also important instead of just sort of seeing them and not thinking much about it. Now, these sorts of things, the peripheral stigmata, looking at the hands, etc., I don't think you need to worry about at all. There's lots of different peripheral stigmata of disease that have lots of different, associations with different diseases. Some of them that are easy to see, you may see simple things like Dupuytren's contractures, and that's fine if you've seen it, but to be honest, you don't need to worry about actually looking for these things. Like I say, even in the emergency department, a lot of this stuff is just not done for lots of reasons. One, there's just no time, and two, it's just far less important. Now, so I'm just waiting till... So in terms of the eyes, you can obviously have a quick look in the eyes. So things like the face are probably worth having a brief look at. You know, you may see jaundice in the eyes. It's important if you're in an area with fluoro lighting, if you feel like they've got jaundice, to actually have a look in natural light, because that's the best way to be able to tell if a patient is jaundiced. Now, again, like I say, I don't think you need to worry about the chest. Okay, so first thing is to do a proper abdominal examination. You need them to be flat, in a relaxed position with their hands down by their sides. Now, this is not always practical for you guys on the road. To be honest, it's not always even practical in the emergency department. It really depends. But as best you can, lying them on their back, you need to expose the abdomen. So even if you don't get them to take their shirt off, exposing as much of the abdomen as you can. Obviously being aware of people's privacy and, you know, playing things by ear depending on the situation, because every situation is different and there will be some where maybe it's not appropriate, but exposing as much of the abdomen as you can. If you can, trying to sort of pull, generally what I do is try and sort of at least get their pants down a little bit so it's right on the pubic bone. Now, we like to look at the abdomen, so just having a look and seeing, are there any scars? You can ask them then about the scars if they haven't told you that they've had abdominal surgery. Looking for obvious signs, so you might see obvious masses. You might see, you know, a pulsatile mass in the middle of the abdomen. It's not common to be able to see one, but you may see it. And let's see what else they say. So obviously here they've got the different quadrants. Some surgeries, older surgeries, will have different scars to the ones that are done now. So caput medusa, which you may want to look up, you find it often in patients with liver failure. And what they'll often have is ascites. So that's the typical sort of quite distended, round, tense abdomen that almost looks like a pregnant abdomen, which means that they've got ascites. So they've got acidic fluid in their abdomen, in the peritoneal cavity, and then they get this, due to venous congestion, the veins from their umbilicus come out like this, and they'll be sort of all the way around, and that's what's called caput medusa. Again, like I say, it's probably less significant to go looking for, but in inspecting the abdomen, you may see it. Now, stomas are important, and it's important to then ask the patient about it. There's lots and lots and lots of different types of stomas. So some people just have a colostomy, some people have a loop colostomy or ileostomy, some people will have even ileal conduits, which is then urinary, like urine is coming out of the bag as opposed to stools. But so it's important if you see a stoma to ask the patient, what surgery have you had? What type of stoma is it? Is your stoma acting normally for you? So they will know, people who have a stoma know that if it's normal, if it's underactive, if it's looser than usual, all those sorts of things. They will know all about it, and you can ask them. So it's really important to just ask the patients about their stoma. So next, when we talk about, obviously there's sort of 4 points of the focused abdominal examination. We inspect, palpate, percuss, and auscultate. So When it comes to palpation, the things that are good to do is start away from the pain and start with light palpation. So you're just sort of having a feel, seeing if you can feel anything, obviously seeing if they have tenderness to light palpation. So obviously if someone's complaining of pain in the right lower quadrant, I would start over on the left-hand side and work my way sort of up and across the abdomen and finish in the painful area. So that's important, so they don't sort of get worried that you're just going to come in there and poke them straight away. So as I said, light palpation, and it is really quite light, and then you go back and repeat that. So again, so as he's doing here, it's important to watch the patient's face as much as you can. Lots of people will sort of tell you it's not sore, but you'll see them grimacing, particularly in kids or anyone else that's non-verbal dementia patients and things like that. That's also really important to watch their face. Then you go back, obviously, and repeat it with deep palpation, and often sort of then a bit of a focused, if you find an area of pain, you may focus around that area. So in terms of palpating for organs, they're not really things that are necessarily super beneficial pre-hospitally. You can palpate for the liver. So as they're showing here, you start right down in the right lower quadrant. You get them to breathe out, and as they breathe out, you move your hand up and you're moving your sort of index finger sort of on an angle to try and catch the liver edge. As they then take a deep breath in, they drop, the abdominal contents drop because of the intrathoracic pressure, and so the theory is that you will feel the tip of the liver hit your finger when it happens. Sometimes livers are really obvious and you'll just be able to feel it when you're doing an abdominal examination. If you do feel it, what we tend to do is measure from the bottom sort of mid-clavicular line, the bottom of the rib there, and measure how many fingers, or sort of estimate a number of centimetres if you can. So, you know, it may be 3 fingers or 5 centimetres below the costal margin. The other thing which we will talk about when we talk about cholecystitis is Murphy's sign. So what you do to elicit Murphy's sign is essentially what is happening here with the liver palpation. And what will happen is you don't need to start right in the right lower quadrant. You can start further up in the abdomen, but you basically pop your hand in that position, basically where the gentleman has it now, and get the patient to take a deep breath in. Now, if that gallbladder, which sits just under the liver, if you remember your anatomy, if that gallbladder is inflamed, as it comes down and hits your hand, they will take a sharp breath in and sort of catch their breath and complain of pain. That's Murphy's sign. So that's important to know. Now, then there's the splenic palpation, which, again, like I say, it's not really that important for you. You often won't be able to feel the spleen. It's really well tucked up under the ribs there. Sometimes you'll feel the liver all the way across at the side of the spleen. Sometimes you will be able to feel it. Now, blotting the kidneys, I think that is something important for you guys to know. So essentially what you do is using, if you're right-handed, for example, or I mean, everyone should examine with their right hand, because we technically say you should examine from the patient's right-hand side, so the right-hand side of the bed, or the left-hand side as you're looking at it. So using your right hand on top and your left hand underneath. So you reach underneath with your left hand to where you sort of assume the kidneys are. So basically the flank area at the back, you can feel it on yourself between your iliac crest and the bottom ribs. And you pop your hand there, you put another hand on top of the abdomen and you blot. So with the bottom hand, you basically try and spring the kidney up into your top hand. Now, there's a couple of things that you can elicit from this. One is if someone has a really big kidney, you'll be able to feel it. Now, that's not common, although if someone has, for example, polycystic kidneys, you will probably be able to feel them because they're really big. Often you cannot feel the kidney, but if someone has pain in that area, and particularly if it's one-sided pain, that can help with your differential diagnosis. So then looking for pulsatile masses. Now this is really hard. In a skinny person, you'll be able to feel the aorta. You try and measure it out as best you can. But if you feel a really big mass that is pulsatile right in the middle there, then obviously you have to be concerned about a AAA. Now, percussion. So, I'm not sure how much you guys have been taught about percussion. There's probably only a couple of valuable points. Now, you work in a pre-hospital environment and you're often not going to be able to hear well enough to percuss anyway. But the main points are that with your left hand, you place your middle finger flat against the surface. So in this, we're talking about doing it on the abdomen, and you use either one or two fingers from your other hand to tap on the middle of that that finger that's sort of against the abdomen. Now, the things where I find it really useful in the abdomen is when you're assessing for peritonism. So localized peritonism. So obviously if a patient has pain somewhere, one of the things we talk about is often rebound tenderness. Now, actually pushing deeply into someone's abdomen and then pulling your hand away can be quite nasty, and a gentler way, and what we're seeing there is peritonism. So you're getting irritation of the peritoneum, and that's why they get that severe localized pain as you pull your hand away. So a sort of gentler way of testing that is percussion. So what you can do is around, you can do it on the whole abdomen, but the area that they've complained of pain on palpation, if you percuss that area and they're tender, then we assume for the interim that they have localized peritoneal irritation. Someone who is sore all over to percussion is a concern that they've got widespread peritonism. So that is probably my biggest advice on how to use percussion, because like I say, actually hearing things and actually hearing anything in the abdomen is quite hard. You can use it to mark out liver borders and things like that, as this guy does in this video, but I think the most useful thing for you is using it to elicit signs of localized peritonism. So we'll just skip over those bits. Okay, so then we're going to auscultate. So important things for auscultation is bowel sounds. So technically you need to be able to listen for 2 minutes to be able to say that they're absent. So what you'll generally do though is you'll pop your stethoscope on, and normally within a couple of seconds you'll hear bowel sounds. Now if you can hear okay, things like that, if you've listened to lots of abdomens, you can comment on things like if they're active, if they're scant, if they're tinkling bowel sounds. There's all sorts of different ways to describe bowel sounds. The most important thing initially is, are there bowel sounds? So if you've been listening for a while and you're not sure, you need to try and listen for the full 2 minutes. If you think you're just not able to hear anything, for you guys it's probably less important, but what is important is to hand that over when you get the patient to hospital. Say, I've tried to listen for bowel sounds, I listened for 2 minutes and I could not hear any. You can sometimes change the position of your stethoscope to make sure, but like I say, if you're going to say there's no bowel sounds, it has to be 2 minutes. That's the main thing. Obviously, as in this video, you can listen for aortic bruits and renal artery bruits. They're often difficult to hear, and it won't change your sort of initial examination anyway. Now, there's a couple of last things that this gentleman talks about to complete his examination. So obviously most of these things I don't expect you to do, but what is important, I certainly wouldn't expect you to be doing a rectal examination. The important thing to ask, it's really important to ask about genitalia. Now, things like testicular torsion can present with just abdominal pain. So it is really important to ask about it. If you're really suspecting it, you need to have a look at the testicles because it will raise your suspicions. Obviously, you want to do that with someone else in the room. You want to have a chaperone. If it is a child, you know, explain to mum that you want to have a look and things like that. Now, hernial orifices, we'll talk about hernias. So they're mainly talking about the groin. You can feel the groin over pants to get a general idea, and you can essentially just place your hand either side in the sort of over the inguinal canal, and you can even ask them to cough and things like that, or just ask if there's pain in those areas to give you a bit of an idea. I would caution you to be a bit careful in how much you're exposing patients. Okay. Okay, so we've talked through the focused abdominal examination. So like I said, I wasn't able to find a video on a focused abdominal examination. That's really what I wanted to show you. But it's good to know the sort of full-blown abdominal examination as well. But these are the main things that you need to think about and look for when you have a patient with abdominal pain. So we've gone over all of that. We'll just make sure we've done everything. Palpation. Good. Okay. Now, I just wanted to talk quickly about using analgesia in abdominal pain. So, there's a couple of things to know. Firstly, I think, you know, you need to treat pain. That's part of your job. If someone has pain, it's important to treat it. So starting with, we talk about the pain ladder. So if you haven't heard of this, you can just Google WHO pain ladder. So it basically states that you start with simple analgesia. So you start with things like paracetamol and you work your way up. Now, importantly, opioids obviously are your biggest asset for you guys. It's going to be the thing that you can use to treat abdominal pain. Now, there used to be a lot of talk about not giving people too much pain relief. If you get rid of their pain, we won't be able to find the pathology. We won't be able to elicit examination findings and things like that. That's absolutely untrue. So if someone has abdominal pain and you think it's severe enough that they need analgesia, give them analgesia. Give them opioids. There obviously is a lot of concern as well surrounding drug seekers and abdominal pain. I think that you need to be really quite cautious on withholding analgesia just because, for example, a way a person looks or because you've heard something before. I totally understand. I've been in your shoes or the shoes you will be in, and sometimes there are people that are well known to you and other crews that are known drug seekers, but again, just because they're a drug seeker, it doesn't mean they don't have true pathology. So I think you just need to be a bit cautious of that, and it's best to just treat them. Now, I'm not 100% sure on what routes and management you guys have for pain at the moment, but like I said, simple pain relief is good to begin with. Using intranasal fentanyl in kids is great. It works really, really well. It's easy. There's no needles involved. So that's great. And then either IV morphine or IV fentanyl is absolutely fine in an adult. If you are working in a service that has either option, they're both fine. Obviously, then the important thing as well is reassessing. Is the analgesia doing anything for their pain? Is it actually making it any better, or is it not really helping at all? So in terms of management in abdominal pain, for you guys, there's not a lot of really specific management for different types of abdominal pain. So obviously, as with any patient, we do our primary survey, our doctor's ABC, and you want to fix and treat any of those things. So someone who has abdominal pain may have circulatory collapse. They may be in shock, and so that is your primary treatment course at that time, is to treat their shock and get them to hospital. There could be any number of things causing that pain and the shock, so the important thing is to make sure you treat that and get them to hospital. Now, analgesia, as I've said, analgesia is important, and it's good to use that as you can. Now, antiemetics, so there's obviously a couple of different types, and again, I'm not 100% sure how much of what you're carrying at the moment, or if you've got IV and oral options or just IV and IM. So obviously with children you can't use Maxilon, but if you're authorized to use ondansetron in children, then that's great. Use ondansetron, it's good and it will work well. Now, Maxilon, you do want to be somewhat cautious in bowel obstruction, so possibly with abdominal pain, ondansetron is a better option to go for. That said, ondansetron can be quite constipating, and it's something that's tended to be avoided in people with constipation. But like I say, given that, it's just a few options for you. Now, IV access and fluids. So if you think the patient is, unwell enough and they need IV analgesia and things like that, access is always really good. It means you've got a place to start if things get worse. So that's always good. And fluids. So obviously you need to fluid resuscitate, but we do still like to think of minimal fluid volume resuscitation as an important point. So if the patient has signs of sepsis, so if they're hypotensive, tachycardic, febrile, with their abdominal pain, so you think it's likely some sort of infective source, then you can definitely use a reasonable amount of fluids, so maybe up to 20 mils per kilo. It's really important to make it clear how much fluid you've given once you get them to hospital. If your concern is any type of PR bleeding, if you're worried that they've got a ruptured AAA or anything like that, then we want to be doing very minimum fluid volume resuscitation. So I'm not sure if you've done your trauma subject yet and you've talked about shock and why we treat with minimum fluid volume, but obviously the main thing someone in that situation needs is 1, blood products, and 2, surgery. We don't want to dislodge clots that may have formed. We don't want to hemodilute the blood that they still have in their circulation and give them less oxygen carrying capacity. So titrating fluids to GCS is a really good way of managing that. If someone has, if they've got a GCS of 13 or 14, then we're pretty happy and just get them to hospital. Like I say, they don't even need a doctor in an emergency department. They need a surgeon. That's what they need. And the quicker they get to that person, the better. Okay, now one of the things that I wanted to make really clear, we're going to talk about lots of different causes for abdominal pain, lots of different pathologies. The most important thing that I want you guys to be able to recognize is the acute surgical abdomen. So in this situation, obviously you'll do as much of your history and examination as you can, but in this situation, it doesn't really matter. It's just important that you recognize that this is an acute surgical abdomen and this patient needs to be in hospital. So these people will be really unwell. The sudden, severe onset of abdominal pain, their abdomen may be rigid and they might have involuntary guarding. So voluntary guarding is when you palpate, someone's actively sort of, contracting their abdominal muscles to guard their abdomen. And sometimes you'll find that in like kids if they're ticklish and things like that, and distraction is a good key. But if they have that tensing when you're palpating and they're not actively tensing, that's involuntary guarding. signs of sepsis, and obviously hemodynamic compromise. This is, if you have these signs and symptoms, this is an acute surgical abdomen, and this patient needs to be in hospital as soon as possible. They need to have lots of things done all at once, and they need to go to theatre. So that's the biggest thing I want you to be able to recognize. Obviously, it's always really good to be able to spend the time and try and understand, and, if you can pick the patient that you think has appendicitis, that's great. But the acute surgical abdomen is the most important thing. Okay, now we're going to go through a bunch of other pathology that you may see along the way, and we're just going to talk about all of them. Now, I'm not really going to talk much about management. What I might do is sort of just mention some of the management that gets done in hospital, more for your information. As I said before, management with abdominal pain is really, it's symptomatic. So it's basically your primary survey, your analgesia, your antiemetics, your IV access, your fluids. But knowing a little bit about what happens with these patients, I think is good. So we'll talk about that. So appendicitis. We all know about appendicitis. We've all heard about it. So it's essentially an acute inflammatory response in the appendix, resulting normally from obstruction. So often what happens is the appendix, and I don't have a little picture, but hopefully you guys know that the appendix is a little organ that sits off the end of the cecum. It is reasonably redundant, and obviously lots of people have had their appendixes out, and we don't see any sort of major side effects from it. But what can happen is, because it's a little tubular organ, is they can get often a fecalus, so they get a little bit of poo stuck in the open end of it, and it's a closed-ended organ. So because it's now blocked, it's a secretory organ, so it has ongoing secretions, which causes raised sort of intraluminal pressure, so inside that organ. With that raised pressure, you then get impaired lymphatic and venous return, which then leads to ischemia. And with the ischemia, it's bacterial invasion. And as that all happens and there's lots of swelling and things like that, you then get irritation of the local peritoneum, and that's when you actually get your migratory pain. So because the appendix is a visceral organ, you start with the classic generalized central abdominal aching. So a lot of the organs from, and it's all based on their origination in embryo, and so where their nervous system comes from, a lot of organs will just produce generalized pain. And that's what happens with the appendix when this sort of process first starts. They get generalized central abdominal pain. When that pain migrates, what's happening is this end part of the process where you're getting the peritonitis, and so you're getting local chemical irritation of the peritoneum, and obviously that can sometimes rupture as well. So as I said, the pain is often initially central, and it now radiates. Now, one of the things that's important to be aware of, as I said earlier, classical appendicitis is quite uncommon, and that's to do with lots of things. Obviously, firstly, there's no black and white in medicine, but secondly, there is lots of different places that the appendix can sit. So the appendix can be retrocecal, and therefore it's right in behind the cecum and sort of right down in the pelvis, and so they'll get sort of very vague type symptoms and vague type pain and maybe minimal examination findings. So that the location of the appendix can change some of the history, but often the thing is it starts with a general central pain and it changes. Now you get associated symptoms, and again, not everyone gets all the symptoms, but the ones that we like to know about are nausea and vomiting, the anorexia, so lack of interest in appetite. Sometimes they'll get diarrhea, and often low-grade fevers. So there's a couple of sort of special signs that we talk about. Now, the first should really be McBurney's point tenderness. So McBurney's point is halfway between the umbilicus and the iliac crest, the right iliac crest. Halfway between there is, if you push, that should be about where the appendix is, and if you've got an appendicitis, that should be where it's sore. Like I said, not always the case, but that is our classic right lower quadrant tenderness point. Now, Rovsing's sign is something that's easy, that will sort of crop up just with your examination anyway. So what Rovsing's is if you push on the abdomen, or push and release, so essentially rebound or percuss the abdomen on the left-hand side, you will get pain on the right iliac fossa, the right lower quadrant. So as I say, that's often something that you just find with your examination, not on purpose. Obturator sign is one that's sort of less often performed probably, and not necessarily the most practical for you guys to be doing pre-hospitally. But essentially, using the right leg, it's lifted up, the knees bent at 90 degrees, and you do internal flexion and internal rotation of the hip, which stretches the obturator and the psoas muscle, and that will then cause pain because it's underneath where the appendix is located. So that's how that works. But like I say, less sort of necessary, I guess. Now, there's a couple of appendix sort of scores that can be used. They're very similar, but they're just sort of changed slightly for pediatrics. So the pediatric appendix score, you obviously get points for different things. So if they've got percussion or cough tenderness, are they able to hop? The anorexia, pyrexia, so fevers, nausea, vomiting, tenderness in the right iliac fossa. And then these things, obviously, you guys can't do these two. So your white cell count and your neutrophil count obviously give you points. And then the migration of pain. So add up all those points that they scored. Appendicitis is unlikely in less than 5, possible in 5, and likely in greater than 6. Now, the Alvarado is used for adults. So, again, similar things. Migration of pain, anorexia, nausea, tenderness in the right lower quadrant gets you 2. Rebound pain, high temperature, high white cell count, and shift of white cells to the left. That basically just means they have a high neutrophil count, which is often associated with bacterial infection. So, score out of 10. Now, generally what they say is 1 to 4 is, again, appendicitis unlikely, 5 to 6 is appendicitis possible, and 7 to 10 is appendicitis likely. Now, what this can sometimes do is change hospital management. A 7 to 10, depending on the patient, may mean they'll go straight to theatre. A 5 to 6, they'll wait for an ultrasound. A 1 to 4, they might observe. People may be happy to send them home and just get them to come back. It can be different things. Now, bowel obstructions. So obviously a bowel obstruction is a mechanical or functional obstruction of the small or large bowel. That's quite straightforward. There's obviously many different causes. Now, small bowels are often due to adhesion. So as I was talking before, patients who had previous abdominal surgery, it's really important because adhesions are very common in anyone who's had any sort of abdominal intervention, particularly people who had abdominal intervention years ago, because some of the products that we used were more, irritant, I guess, to the internal organs, and there was an inflammatory response as a process. And the other thing is hernias. Large bowel is more often due to a volvulus, which is a twisting of the large bowel, or tumours. So often a large tumour has caused the bowel obstruction. Now, with the presentation, it's often dependent on the level of obstruction, but they'll often get abdominal pain. They might have a distended abdomen. They may get vomiting, which may be fecal, so it's an important thing that you ask these people if they've had vomiting or if you see them vomit. If it smells like poo, then it probably is, which is awful, and you might not want to tell the patient at the time, but it can definitely happen. And constipation, so not opening their bowels and not passing wind, is important as well. Sometimes these patients will have diarrhea, which is essentially overflow diarrhea. Now, things that may happen, which I forgot to talk about with appendicitis, but things that may happen in hospital with a bowel obstruction, obviously they'll get worked up. They'll obviously get some sort of imaging. It's often these days a CT scan. We used to talk a lot about x-rays, standing and lying abdominal x-rays and air fluid levels, but depending on the patient and their age and their exposure and risk with radiation, they'll often get a CT scan. Now, lots of bowel obstructions are managed conservatively. So if it is something where there's no obvious, if there's an obvious cause of obstruction, for example, a tumor that is the obvious blockage and that's the transition point in the bowel, then that patient needs to have an operation because that's not going to go away. And they will have an operation. If there's a less obvious transition point, and for example, it's a small bowel obstruction and it's believed that it's probably due to adhesions, then they often get conservatively managed, at least for the first few days, with what is colloquially known as drip and suck. So they get IV access and obviously cannulas, so cannulas and IV fluid replacement. They get rehydrated and then they get fluids and electrolytes, their maintenance amount plus whatever they're losing each day, and then they get a nasogastric tube and we drain their gastric contents, and if they have high outputs then they get more fluids back in. They often get managed conservatively for a couple of days, but if that doesn't work then they will often need an operation. Now, intussusception. So intussusception is an invagination of a portion of bowel into another portion of bowel. So we talk about proximal, which is closer, and distal, which is further away. So as you can see in this picture here, this is the proximal portion of bowel, and it's coming in to the distal portion of bowel. The commonest occurrence is in the segment of the ileum moving into the colon through the ileocecal valve, and it is often sort of in the 2-month to 2-year age group. Now, what happens is this, so sometimes this can basically come in and out and in and out. That's an important thing to know. But essentially the trapped portion of bowel can end up with its blood supply cut off, so it becomes ischemic. And then the mucosa starts to slough off, which creates the classical described red currant jelly stool. Now, the presentation of these patients is often an intermittent colicky pain. Can be really severe, and it's often associated with the child drawing up their legs. It's often episodic, so the description that you may get from parents, which is really important because it's often not clear, is that they might just say their child is just inconsolable or really irritable. They just scream and scream and scream, and then they stop and they're fine. That's something that intussusception should always be considered in that sort of patient. So that's something important to know. And then in terms of bowel motions, they talk about this classic red currant jelly stool, but to be honest, it's a really late sign, and even if it's not there, intussusception should be suspected. Diarrhea is common, and you shouldn't sort of just assume that it's gastroenteritis just because they have diarrhea. So like I said, the young child who is irritable and inconsolable on and off, that's someone to sort of consider that they may have intussusception. If Intussusception in hospital, generally what happens is they will get an ultrasound, and there's a classical donut sign on the ultrasound, which is essentially you can see circles within circles, and that's just the lumens inside of each other. There are a couple of different ways of managing that. Sometimes they do an air enema, so they basically put air up their rectum, and that can basically get it back out, get the sort of internal lumen back out where it's supposed to be. Sometimes they do need to go to theatre. So perforated viscus. So essentially perforated viscus is just a hole in any hollow viscus of the abdominal tract. There's lots of causes depending on the location. So if you're talking, things like the stomach, it's classically the ulcer that has perforated. Right down in the sort of lower part of the abdomen, it might be a perforated diverticulum or something like that. It's obviously a common thing that you need to think about in penetrating trauma, but it can happen spontaneously. Now with upper GI, so things like your perforated ulcers, it's often a sudden onset, really severe abdominal pain. They might have signs of peritonitis. If you try to give them things orally, which often happens because it may initially be misdiagnosed or it might be unclear what they've got, often oral things will really irritate their pain, because they will get, obviously they've got a hole in their stomach, and then if they start producing acids and things like that, it will leak out and they get really severe pain. Lower GI perforations are often more gradual, so particularly things like diverticular perforations, and we'll talk about diverticular disease a bit later on. It is a gradual onset. They'll often have a sort of micro perforation, and it can often be walled off, hence why, and because it's lower down in the abdomen, they just tend to have less acute signs, and it'll be a gradual onset of signs and symptoms. In terms of things that happen in hospital with those people, again, we do a general workup. We do imaging to look for the perforation. You can do things like a mobile chest x-ray and look for air under the diaphragm, which is a big sign. And then often they'll end up with things like a CT scan to tell you the extent. And depending on, again, what it is and where it is, it's dependent on how it's managed. If it's things like a perforated ulcer, those patients probably do need to have, rapid intervention. But things like perforated diverticular, they do often wall themselves off, and they may not need to have an operation. They may still, but they may not need to have an operation. Diverticular disease. Oh, and I've lost my photo. I had a little picture. Oh, there it is. So with diverticular disease, so what we get is, so diverticulosis is the presence of these small outpouchings in the intestinal wall. So these bits down here is diverticulosis. Now, diverticulitis is when you get inflammation of those, and then you can also have diverticular bleeding, which I'll talk about in a minute. So diverticulosis is often associated, we think, with a low fiber diet and high intracolonic pressures. So patients who have constipation and have lots of straining are more likely to have diverticulosis. It's more common with age, and most people sort of probably above the age of 60 or so have some sort of diverticular disease. It's just dependent on how much they have and how bad it is. One thing to be aware of, obviously it's normally in the distal colon, so in the distal part of the descending colon. But one thing that's important to know is that Asian populations can often get pain over this side or at the ascending colon. So that's important. What else? Now, so diverticular bleeding. So diverticular bleeding can be very, very severe. So with these outpouchings, because of the way they are through the striae in the colon, this bit that's stretched here basically has an artery stretched over the top of it. So if, for example, something sort of gets in the pouch and scratches the mucosa or something like that, they can have arterial bleeding, and it can be very significant bleeding. So they will generally present with really bright red blood, and often it stops on its own, but sometimes it doesn't. So yeah, someone with really significant PR bleeding, it may be from a diverticular bleed. So in terms of their presentation, simple diverticular, if that's all it is, are asymptomatic. Diverticulitis is often left lower quadrant pain, like I said, possibly on the right side in certain populations, so those Asian populations. And they often get fever, so they sort of get almost like mild flu-like illness symptoms. They'll get a little bit of fever and be a little bit generally unwell and some malaise. They often have a change in bowel habits, so they might have just a little bit of diarrhea. And then there's obviously on top of that, they may have had these symptoms for a few days and then present with worsening pain. So that would be when you think about the perforated diverticular that we talked about with the perforated viscous. And obviously they need to be assessed for that. Like I said, diverticular bleeding is often massive PR bleeding, and so they obviously need transport to hospital. Now, in hospital, often diverticulitis can be managed just with antibiotics. Depending on their severity, they may actually be able to go home with antibiotics, just with some oral antibiotics. Sometimes they need to be in hospital. And then if there is a perforation, what we'll often do is keep them nil by mouth for a few days, see how they go. If they start to improve, let them eat and drink, possibly rescan them at some point, and make sure that that's no worse. But as I said, they can often wall off themselves. Now, biliary tract disease. So biliary tract disease, there's obviously lots of different parts of the biliary tract, and therefore lots of different things that can happen. So obviously, we get gallstones, which is referred to as cholelithiasis. You can also get choledocholithiasis, which is gallstones in the actual biliary tree as opposed to in the gallbladder. And then cholecystitis, which is inflammation of the gallbladder. Chronic acalculous gallbladder disease. So, as I say there, it's due to the sort of natural movements of emptying the gallbladder don't really work very well. They can end up gangrenous. That's often associated with things like cholecystitis. We can have other things in the bladder. We can have congenital defects. We can have tumours of the gallbladder and the bile duct. So there's probably two things that are important to know. Your acute cholecystitis. So it's acute inflammation of the gallbladder. Now what happens is patients often have gallstones. They'll often know that they have gallstones. They'll often have had attacks before. What happens is those gallstones, when the gallbladder contracts, the gallstones block the cystic duct. So the gallbladder is contracting against the cystic duct. And that's important because it often happens when they eat. So when they eat something high fat, high salts, they'll tell you that they had fish and chips for dinner or KFC or something like that. So the poor little gallbladder is trying really hard to produce all this bile to help break down all this fat, and it's pushing against this blocked cystic duct. So the blockage, they've then got lots of bile sitting there, it leads to stasis, and then they get inflammation and thickening of the gallbladder wall, which irritates the surrounding structures. Now, it can lead to perforation, although, like I say, it's often really classic. They had something fatty for dinner. They know they're not supposed to, but they thought they were going okay, so they did, and then they get pain, and they know that it's their cholecystitis. There's lots of risk factors involved, so female, increasing age, pregnancy, oral contraceptive pills, obesity, diabetes, certain ethnicities, rapid weight loss, they can all contribute. So they get right upper quadrant pain. They can often have fevers, vomiting, nausea. Our Murphy's sign, so we spoke about this before, but basically you ask the patient to take a breath out and you place the hand gently in the right upper quadrant, and then you ask them to breathe in, which drops the abdominal contents, and the gallbladder hits your hand and their breath catches. That's Murphy's sign. Now, ascending cholangitis is an important one to know because they can present like a sort of similar to a cholecystitis. They're essentially a type of biliary disease, but these patients can be really, really, really sick. So with essentially what it is they get an inflammation and infection of the bile duct due to bacteria that comes up from the duodenum, so often through the sphincter of Oddi up through the duodenum, and then they get inflammation and infection of the bile duct, but it can also spread up into the liver. Now that can cause really big problems because they can obviously end up with liver abscesses, but the liver has the portal circulation, so you can then get this, rapid spread of bacteria through the body from that portal circulation. So often, as I said, what happens is they access the bacteria accesses the biliary tree through the sphincter of Oddi. There's a number of risk factors. So anyone who has a known stone in the duct, so choledocholithiasis, they're at high risk because they have something sitting in the duct, which puts them at high risk of infection in the duct. Previous instrumentation, so anyone who's had an ERCP, which is an endoscopic retrograde cholangio something. Anyway, patients will often be able to tell you if they've had one. Basically what happens is it's like having an endoscopy. They put an endoscope down, they find the sphincter of Oddi, they go in with a sort of little device that goes in and opens up the biliary tree. And some patients, if they've had lots of stones, may have also had a previous biliary stent, and that obviously any piece of sort of plastic or material in the body can lead to infection. So any of those things puts them at higher risk. Now these patients often present jaundice, so they'll often be visibly jaundiced. They'll be yellow. They can have right upper quadrant pain, but they don't always. They might be febrile, and then they can often have signs of sepsis and shock. So they'll be hypotensive, confused, tachycardic. So as I said before, these patients can be really unwell, which is why it's important to know about. If someone does, if you do get a patient like this, the main things are obviously fluid resuscitation and transfer to hospital. In hospital, the important things, so for cholecystitis, we essentially manage their pain and treat them with antibiotics. We tend to not take the gallbladder out when it's acutely inflamed because it's at high risk of perforation, and most cholecystectomies are done laparoscopically nowadays, so we try not to do open operations. So we often settle the gallbladder down and then get them back for an elective cholecystectomy. Sometimes if they're really severe or if they perforate, they will need to go in and take them out anyway. Now with ascending cholangitis, these patients need aggressive fluid volume resuscitation. They may need inotropic support in ICU. They'll need extensive antibiotics, and they will need an ERCP, which obviously clears out. The first thing is to clear the bile duct, so they may have, stones in the duct or sludge just sitting there, so releasing that is the first thing because you need obviously source control of the infection. Sometimes they may have developed abscesses external to the gallbladder and they may need drains put in. They'll obviously need a cholecystectomy at some point, but again, we try to avoid that at the time. And then obviously being aware of the possibility of liver abscesses and looking for those because they may need drainage as well. So with our ruptured abdominal aortic aneurysm, so obviously a AAA is a localized enlargement of the abdominal aorta. Now, lots of people have them, lots of people don't know they have them, but some people will know they have one that's 4 centimeters and it's being monitored or whatever. But essentially what happens is you get a degradation of the tunica media, which is part of one of the mucosal layers in the aorta, and due to that, you get elimination of the elastin, which renders the wall more susceptible to high blood pressures. Now, there's a whole sort of cellular level pathophysiology that happens with this degradation, and it's often associated with things that also contribute to, coronary artery disease. So things like smoking, diabetes, they affect the endothelial and they change the cellular structure and the inflammatory response at the endothelial level. And then you get, with the changes in the endothelium, high blood pressure then causes turbulent flow, etc. But obviously you get this enlargement of the abdominal aorta. Now, if that ruptures, obviously the abdominal aorta is really large and so therefore it bleeds a lot. Now, sometimes you'll get a contained rupture, or you might get, it's often higher up, but you can also still get dissections. But the things that are important are sort of this, and it's often the vague things that just don't fit is important to think of abdominal aortic aneurysm. So they might have sort of back or abdominal pain, but when you palpate, it's not necessarily tender. Hypotension, they may have had a sudden loss of consciousness but now be awake and tell you they're fine. And they might have a palpable pulsatile mass in the abdomen. Now, obviously, if you at all suspect this, as I said before, minimum fluid volume resuscitation, resuscitate as you need to, but try and avoid copious amounts of fluids, and rapid transfer to hospital. Notify the hospital. Make sure, and it obviously depends on the area you're working, but going to a centre that can tolerate or can manage this. Now, most places in the wider Brisbane area would be able to manage a AAA, but depending on where you're working, some places may or may not have the facilities to do that. If this patient presented to the emergency department, there's obviously a number of things. Oh, and notifying your hospital is always really good as well for something like this. If you truly think it is and the patient is shocked, let the hospital know. Because the things to do are, obviously, we want at least 2 large cannulas, 18 gauge at a minimum. We would need a full set of bloods, including sort of cross-matching blood products. And in a hospital, as much as possible, we would resuscitate with blood products, and they would get imaging and they would go to theatre. Sometimes they don't even go through, say, the CT scanner. Now that we've got such easy access to ultrasound in the emergency department, they may just get ultrasounded and then go straight to theatre with the vascular surgeons. Now, they try to do a lot of things endovascularly, so not open surgery, but it's not always possible. If it's a ruptured AAA, it's often just an open repair, and they can't always repair, but they obviously give it their best shot. Pancreatitis, so obviously this is an inflammation of the pancreas. Now, there's lots of different causes. This is a mnemonic to remember them. I get smashed. So idiopathic, obviously we don't really know. Important ones are gallstones, so that is one to definitely know about. Cystic fibrosis is an interesting one. You won't come across it a lot, but it's definitely a possibility. Alcohol is probably one that you will see the most. Trauma, so any sort of blunt force trauma to that area can cause pancreatitis. Steroids, so particularly anabolic steroids, it's a cause. Mumps and other infections and malignancy. There's autoimmune diseases, everyone's favourite, the scorpion venom, and then hyperlipidemia, hypercalcemia, hyperparathyroidism. And again, instrumentation, so post-ERCP can cause pancreatitis, and some drugs as well. These people will, there's acute pancreatitis, and then there's people who have chronic pancreatitis or may have acute on chronic pancreatitis. But they often have a severe, sort of reasonably sudden onset of left side of abdominal pain radiating to the back. Often eases when they sit forward. They'll often have lots of vomiting. They might be hypertensive. They might be you know, profusely diaphoretic. Pancreatitis is really, really, really painful because what happens, I don't know if I put it in here, no. But what happens is essentially because the cells of the pancreas are damaged, they release their sort of like they actually end up basically we'll call it autolysis. So they basically release all the enzymes that the pancreas produces. When those cells get damaged, they release all of them, and then they basically start to break down the pancreas. So it sort of ends up almost eating itself. So it's really painful to have pancreatitis. And there's a couple of signs here that are very uncommon. To be honest, I've never ever seen it, but things to know about. So your Cullen sign is you get a periumbilical discoloration, and then this one here. And then your Gray Turner's is flank discoloration, which is due to a retroperitoneal bleed, and that's often with necrotic or like necrosing pancreatitis, which is not super common, but it can happen, and those patients get really, really sick, and they spend absolutely months and months and months in ICU. Now, Runson's criteria is something that's talked about, and it's the severity of the acute pancreatitis determined by the existence of certain criteria. So not exactly important for you guys, and there's a lot of things that go into it that are 48 hours after admission, but you know, this is the first part of it. So their age, their white cell count, their glucose, their LDH, and their AST, which is some of our liver enzymes, and then we look at a bunch of other criteria 48 hours after, and it helps to determine mortality. So again, like I said, these ones up here, the 7s and 8s, these are the ones that have really severe necrotizing pancreatitis, and they're in the ICU for months. So upper and lower GI bleeding. So it's important to obviously split GI bleeding into upper and lower. With your upper, you have hematemesis, which is vomiting bright red blood. It's important to really clarify with people if they think it was vomit or if they coughed it up, because that's obviously hemoptysis, and that's different. We're assuming that's from the lungs, whereas vomiting is coming from the GI tract. You want to quantify the blood. You know, is it absolutely everywhere? Is there just a small amount? Coffee ground vomiting. So coffee ground vomiting is essentially digested blood clot, so it's partially broken down blood. So it is still upper GI bleeding, and they vomit it back up after it's been partially broken down. Obviously, one of the important things to ask when people sort of describe dark vomiting is recent food intake. Have they had red wine? So sometimes they might freak out and think it's vomiting blood, and it's actually not. And then melena. So melena is the passage of black tarry stools as a result of bacterial degradation of the hemoglobin. So true melena is black, sticky, foul-smelling, absolutely foul-smelling stools. And it is a result of upper GI bleeding, and that blood has traveled all the way through the GI tract and been broken down and creates this awful smelling stool. Then you can get, when it comes to PR bleeding, so when it comes to PR bleeding, you can have anything from bright red blood, which would be things like I spoke about before, diverticular bleeds, all the way through to melena, but there's a big variation as well in the middle. So you may have, say, bleeding on the right-hand side of, the ascending colon, and that is going to present probably quite dark by the time it comes out, but it is not true melena. So it may be sort of dark stools, but it's not necessarily tarry and really foul-smelling. Now, esophageal varices, so these are basically large veins at the distal portion of the esophagus, which are secondary to portal hypertension, so often due to liver failure. So these are often the alcoholics who have liver disease will also have esophageal varices. And they can present with profuse hematemesis. So they, as I said, they're large veins because they're sort of not far from the portal system, so they will get significant bleeding, and they can end up with hemorrhagic shock. They're obviously challenging to manage because they may just have profuse vomiting of blood, and the best thing for them is rapid transport to hospital. There are particular types of tubes that essentially what happens is they get intubated through the airway, and then there's a secondary tube that goes into the esophagus with a balloon on it that you blow the balloon up, and it tamponades the bleeding until they can get to a centre that can go in and repair the bleeding. Okay, hernias. So there's essentially hernias is a protrusion of organs or something through a weakened section of the abdominal wall or viscus. The most common site is in the groin, and the only effective treatment is surgical repair. Now, there's a number of different sites. So obviously in the groin we have two. We have the indirect hernia, which comes down here through the inguinal canal, and then we have a direct inguinal hernia, which comes straight through here. We've obviously got the femoral, which is down right in the femoral canal. We've got the umbilical, which is lots of people will have seen. You can have epigastric incisional, which is at any site, any previous surgical incision. And the other thing, so the main things about when to be concerned with hernias. So lots of people have hernias, lots of people, they can reduce them themselves. If someone with a known hernia develops sudden onset severe pain in that site, that's really important. If that is no longer reducible, particularly if the patient was able to say to you, like, it normally just goes back in and now it won't, the concern is the hernia is incarcerated. So lots of hernias are reducible. So when, even though sometimes it takes a bit of effort, when you sort of squeeze on the contents that have been pushed through and put some consistent pressure on there, it will pop back through that defect in the abdominal wall. However, if you can no longer do that, then, for example, some of the small bowel may be in an umbilical hernia. And what happens is, because that's now stuck there, the blood supply gets cut off. So first the venous return gets limited because those vessels are easier to compress, and the lymphatics gets compressed as well, which then leads to increased pressure, increased swelling, and then their arterial circulation gets cut off and they become ischemic. So that portion of bowel or whatever is in that hernia is, you can assume, is now dying. The other important thing is if they've got fever or if they're hemodynamically compromised, so essentially signs of sepsis. Now, an important thing that I recently learned about is that someone with a history of bariatric surgery, internal hernias are more common in those patients. So obviously this is not something you're going to be able to see, but it's something to be concerned about. So if someone has a history of a gastric bypass in the past and they now have severe sort of upper abdominal pain, you need to be concerned about an internal hernia, and they need to obviously come to hospital. Now, with hernias, obviously, as we said, the only way to fix them is surgical repair. In general, a hernia can be sort of an elective procedure until it becomes incarcerated, and then they need to have an operation urgently. Gastroenteritis. So everyone knows about gastro. It's often viral. It's obviously an inflammation infection of the GI tract, which leads to vomiting and diarrhea. The most important thing is it's a diagnosis of exclusion. It's really easy to fall into the trap of they've probably just got gastro, and yes, a lot of the time they do just have gastro, but it is a diagnosis of exclusion. Particularly in a child, you should never assume that the child has gastroenteritis until you've ruled out more sinister causes, particularly if they only have vomiting and no diarrhea. Now, it can be viral, bacterial, protozoa. Viral is the most common in winter. All the viral bugs go around. That's the usual. Bacterial, there's a couple of different main ones that we think about. And, you get your sort of Salmonella and your Shigella and things like that. Knowing travel history is also important because there's some weird and wonderful things that can be picked up overseas. So in terms of presentation, obviously nausea, vomiting, abdo pain, diarrhea, and lethargy, malaise, fever. May last from 1 day to up to 3 weeks. The biggest concern is dehydration. So again, particularly with children, because they have less reserve, even if it really is just gastro, often if it's gone on for a while, they may need hospital admission for rehydration. Now, in that situation, we often try and do nasogastric rehydration with things like hydrolate because it's a lot more pleasant for children and it's a lot more gentler on the gut mucosa, but they do need to be rehydrated. Renal colic, so renal stones. So obviously stones are sort of small, hard deposits. They're often sharp. They are found in the renal tract. I mean, we have lots of options of stones in the body. Now, they're often formed due to a combination of environmental and genetic causes. So, some people produce more sort of renal salts and things like that than other people. Our classical presentation is loin to groin pain. So it starts sort of in the sort of flank and it comes right round the side of the abdomen and down into the groin. It's often really cramping in nature, and that's basically because the ureters are contracting against this stone to try and squeeze it out. The pain is absolutely severe. The common understanding is that it is the most severe pain that someone can experience, and often people, put it on par with childbirth, and some women even say it's worse than giving birth to a child. So it is really, really, really severe. These people do definitely need opioids. Be reasonably careful with your opioids just because the pain is really severe, but sometimes they will just pass the stone. So if you've loaded them with heaps and heaps and heaps of opioids and then the stone passes, they'll suddenly have all these opioids floating around their body and no pain for it to treat. So they could then end up with some side effects from that. People may get urinary symptoms, so burning, stinging, frequency. They may have blood in their urine. They'll often have nausea and vomiting and sweating. These things often, they do come and go because it's a colic. So you might give them some morphine and some antiemetics and then they'll feel really good. They still need to go to hospital. In hospital, it really depends on the size of the stone. Some stones we allow them to try and pass. Other stones, they end up getting a cystoscopy, so a camera up their ureter, and the urologists often put in a stent, which bypasses the stone, and so the urine can still flow. And then after a little while, once it's all settled down, they will go back in and blast the stone. So they use a laser to blast the stone into lots of pieces and pull it out. They often do that as a two-part procedure because the risk of infection is quite high in acute renal colic. And they don't want to be blasting using laser when there's infection in the renal tract. Pyelonephritis. So pyelonephritis is an infection of the kidney secondary to a urinary tract infection. So essentially, people start with a cystitis or a urinary tract infection. They get retrograde movement of bacteria from the lower urinary tract system into the stagnant urinary tract, secondary often to obstruction. It can be, so some people who say get reflux are, so reflux from the bladder up into the kidneys, they're at higher risk of getting pyelonephritis. So patients will often have preceding urinary symptoms, burning, stinging, frequency, maybe fevers, and then they'll often get abdominal or flank pain, and they can get fevers, they can get really significant rigors. So they might have that rigors that we spoke about earlier, the shaking that lasts for up to an hour, and they can have signs of sepsis. Biggest thing with patients with pyelonephritis is obviously antibiotics. We use quite broad spectrum antibiotics initially, and then we change them when we get our urinary test back. And the other thing is that they can then end up with abscesses, renal abscesses. So monitoring the patient, ensuring that they get better, and if they don't, scanning them and looking for an abscess. Spontaneous bacterial peritonitis. So this is a development of bacterial infection in the peritoneum, so in the acidic fluid, despite the absence of obvious source of infection. So patients, as we said before, often liver failure patients, but sometimes it's things like ovarian cancers or other tumours in the abdomen can get ascites. So they get this buildup of acidic fluid, which is essentially lymphatic fluid that's unable to drain, and that builds up inside the peritoneum, and they get this distended abdomen. Now, what happens is, for some reason, they get an infiltration of bacteria into that fluid. It's not really known, there's no obvious source, and hence the name spontaneous. These patients can be really unwell, so they can have fevers and rigors, they can get worsening of their ascites, and the main thing is that the abdomen becomes really tender. Now, ascites should not be that tender. It's often uncomfortable, but it shouldn't be tender. So if they're really tender and they've got other signs like fevers, or they're generally unwell, they're assumed to be spontaneous bacterial peritonitis until proven otherwise. So certainly for you guys, main point is transferring them to hospital and analgesia if they need, and fluid resuscitation if they need. Once they're in a hospital, they need to have a drain put into their abdomen to drain the fluid, but also to sample the fluid, and then we can see if it's infected. We generally drain the fluid anyway, and then we also give them broad spectrum antibiotics until we have, evidence of a bug. Testicular torsion. So this is really important to be aware of. There's a bimodal distribution with testicular torsion, so in the young child and then sort of older adults. Essentially what happens is the testes rotate, as you can see here. So we've got our spermatic cord, and the testy basically rotates on that, and it's because it's not been fixated properly down here, so on the tunica vaginalis. So if I'm not sure how much embryology you guys did, but there's a thing called the gubernaculum, greatest name ever, that basically pulls the testes down in embryo down into this area, and basically tethers them here inside the scrotum. Now, sometimes they're not tethered properly, and so the testicle can twist on itself around the spermatic cord. Now, what happens, like, it can just be from small movements or trauma, like it doesn't necessarily need to be anything big. But what happens is, because this is now twisted up on itself, it compresses the blood supply to the testes, and so they then obviously become ischemic and causes pain. Now, they can present with scrotal pain or primarily with abdominal pain, so that's an important thing to always think about the testicles. Now, if by any chance you end up looking at the testicles, which, like I said before, you may or may not, depending on the situation, whether you're comfortable, whether you think it's necessary, you'll often get one testicle often looks larger than the other. It may look red. It can be transverse lie, so it's sitting crossways instead of sort of on this slight angle here as this testicle is. And they might have a loss of the cremaster reflex. So essentially the cremaster reflex is if there's sort of a light sensation to the upper thigh of this patient, the testes should sort of pull up themselves. If that doesn't happen, then that's a concerning feature. And they may also have nausea and vomiting. Biggest thing with these patients is they need rapid transport to hospital, pain relief and rapid transport. The testicle essentially has 6 hours for viability, so particularly if it is really acute onset, we need them in hospital as soon as possible. They often get an ultrasound, and then they see the surgeons and they'll go to theatre. Sometimes the testes may not be able to be saved, but the important thing is they still need to have an operation, because often if one side has not been fixed properly and cause testicular torsion, then this can happen in the other side. So they need to have the other side fixated properly. Now, ovarian torsion, so similar thing, but obviously a little bit less obvious because it's internal and it's not going to give us the same sort of external localized symptoms as a testicular torsion. So you get twisting of the ovary on the ligament, which leads to, again, ischemia of the ovary. So the broad ligament, if the ovary sort of twists around that, that is torsion. Risk factors are things like cysts and tumours. Patients who are having IVF and a prior tubal ligation are at higher risk. So these patients often have like pelvic pain. It might be one-sided. It can or may not be sudden onset. They'll have minimal improvement with analgesia. So a woman who has severe pain in one side of her pelvis, and she's really still got ongoing pain despite good analgesia, you need to be concerned about torsion and nausea and vomiting. Now, obviously, again, these patients need rapid transport to hospital. They need to have the diagnosis and they need to have surgery to try and save the ovary. Now, ectopic pregnancy. So this is really important because they can be really unwell. So obviously an ectopic pregnancy is a pregnancy that's implanted outside the uterus, so it can be essentially anywhere. The most common place is in the fallopian tubes, but it can be in the cervix, it can be actually outside in the peritoneum. There's so many different places that it can be located. Risk factors include pelvic inflammatory disease, previous ectopics, tubal surgery, so any surgery on the fallopian tubes, anyone having IVF. They often present with abdominal or pelvic pain. They may have PV bleeding. Now, any woman, sudden collapse, as it says here, any woman of childbearing age, unexplained shock, sudden collapse, anything like that, you have to consider ectopic pregnancy, and they need rapid transport and assessment at hospital. Now, I put it in bold here or capitals, even if they say they're not pregnant. So essentially, we always ask the question. If we're worried, we never believe the answer until we've done a pregnancy test and proven otherwise. People, don't think they're pregnant, and so think if you say, is there any chance you're pregnant, they think that you're asking, are you pregnant? And they say no, obviously. And then there's all sorts of other things like the location, the people who are around, if it's a young woman, they might be with their parents, there's all sorts of reasons that people will say no. So we still want to be thinking about ectopic pregnancy until there's been a pregnancy test done that's negative. These patients, so ectopic pregnancy now can be managed more conservatively, so it can be managed medically. So depending on the state of the patient, if they're hemodynamically stable, they may choose to try tubal saving methods. So essentially things like methotrexate, they might get them to take methotrexate, which will essentially, it affects rapidly dividing cells. So it's going to sort of cause fetal demise and cause the body to then reabsorb that, developing fetus. This can be done, like I say, in patients who are not hemodynamic compromised and the sac has not ruptured. And that can save fallopian tubes and things like that, so it's often used nowadays. But if the patient is shocked, if they're bleeding, if they've got lots of internal bleeding, things like that, then they definitely need to go to theatre. Now, we're almost at the end, so there's just a couple of things that I want to remind you to consider in the patient with abdominal pain. So important things to think about is obviously the heart. Never forget the heart. If it's a weird presentation, if they don't really have actual abdominal findings, if it just doesn't seem right, do an ECG. Particularly inferior infarcts, the inferior portion of the heart sits on the diaphragm, may cause irritation and may, cause symptoms of abdominal pain. The other thing is pulmonary embolisms and pneumonia, so particularly lower lobe pneumonias can cause upper abdominal pain, so they're important things to think about. Now, diabetic ketoacidosis, one of the common features is abdominal pain, and early on in the illness, people may present just with abdominal pain. It's often very non-specific and there's no real intra-abdominal pathology. So thinking of things like, should I do a sugar, etc. And then Addison's disease is another one. So Addison's disease, when patients get unwell with their Addison's, the first thing is they should tell you they have Addison's. If you're at all unsure, and if they have a stress plan and you're able to administer steroids, then you should administer steroids to these people. And just being aware and thinking of it as a possible cause. It's going to be very unlikely that you're going to pick up if it's a sort of new diagnosis Addison's, but someone who's known Addison's can just present with abdominal pain and sort of vague symptoms. Okay, that's everything. So obviously you're not here to ask any questions, but I'll make sure I'm available to answer any questions if you have them. Thanks for listening. I hope this lecture helped.